Yeah. All right. Good morning, everybody. So for my talk today, I'm going to be talking about a clinical program that we do at Children's National called the Blossom Clinic. So just a little bit about our center. We take care of approximately 1,600 youth with type 1 diabetes, and we have a very diverse patient population, both in terms of race and ethnicity and insurance status. You can see on the right there, we have a pretty good proportion of patients actively using CGM, but our group is very passionate and dedicated to improving our AID use as well. So, a little bit of background. This has been discussed extensively over the past day and a half, but youth with type 1 diabetes and suboptimal glycemic control have a lot of barriers to care and achieving the outcomes that we're asking them to achieve that are very difficult to address in the standard outpatient care model. So, our group really wanted to focus on these patients with higher needs and higher barriers to improve their glycemic control and outcomes. And we aimed to do this with a program called the Blossom Clinic, where the aim of this program was to increase CGM and AID initiation to greater than 80% and reduce HbA1c in a clinically meaningful way among participants in the program. So, a little bit about the Blossom Clinic. We called it the Blossom Clinic because it's in Washington, D.C., and we wanted a positive connotation, not regardless of what's going on with the politics at the time. And one of our awesome educators, Kim, actually came up with the name, so we have her to thank. So the program is open to patients 6 to 18 years old who have had at least two A1Cs of 10 or greater or two or more DKA admissions in the past year. And it consists of clinic visits once every 3 months for a total of 4 visits over a 12-month period. And it's an interdisciplinary team, which consists of a provider, a diabetes educator, psychologist, social worker, pharmacist, and health coach. And these are all members of our diabetes team that we are fortunate to have in our diabetes program. And I was able to convince them to join me on this effort to help our patients with the highest needs. Okay, so there's a couple things that the program focuses on. So first is interdisciplinary care. We start each clinic with a team huddle where we discuss the patients extensively and everybody kind of gives their input or concerns around the patient and the things that we feel that we need to address before the patient comes in that day. And the visits are extended. We typically have like 30 minutes for follow-up patients with diabetes, but these are blocked for 2 hours. And then, like I said, the program is 4 visits over a 12-month period. And once you get to the final fourth visit, the team discusses if they've reached the goals that we've been aiming for them. And then we discuss if the patient is ready to transition back to routine care, or sometimes we do keep them until we feel that they have achieved the goals that we were aiming for. So they're not necessarily done at 12 months. We do try to individualize it to the patient needs and their timeline. It's very patient and family centered, so we do make a very strong effort to engage in shared decision making and set goals with the patient and the family. And we do have between visit touch points that can consist of the provider reaching out or other members of the team following up on things that were discussed at the visit or come up in between visits. And we also use screening tools to assess for depression, anxiety, social determinants of health. So all different screening tools, diabetes knowledge, health numeracy. So we are engaging in screeners as well as the pre-visit huddles to kind of assess their needs and identify things that might not come up from just chart review or discussions with the families. There is a very strong equity focus, like everything that we do at our center. So through this clinic, we are able to offer help with transportation that can be in the form of gas cards, Uber, parking vouchers. We have an amazing food pharmacy program that we just run out of the clinic. So we utilize that for the Blossom Clinic as well for anybody who screens positive for food insecurity. We're also able to offer them diabetes supplies. So we do give them ketone strips because often those are not covered by insurance. So we do offer those at every visit as well. And then we have a very strong focus on technology support, as you saw in our previous slide. We do have suboptimal uptake and sustained use of diabetes technology. So we do have a very strong focus of trying to help support patients to uptake and sustainably use both CGM and AID. We give out extra sensors to help with gaps in supplies, which we know is a very common issue. And we also give out CGM adhesives to try and overcome barriers with wear and improve satisfaction with the devices. All right, so the rest of the talk, I'm just going to be discussing results from the first 12 patients who have completed the program. So we're just a little bit over a year into running the program. So the average age was 12.8 years with a mean duration of 4.9 years of having diabetes. And the median A1C at baseline was 11.9. And you can see here that we have a predominantly non-Hispanic, Black, and public health insurance cohort where the technology use is even less than our general population. So a lower proportion of patients using CGM and a lower proportion of patients using AID. All right, so the first clinical outcome that was very exciting was we did see an overall reduction of HbA1c from 11.6 to 9.9 in the 12 patients who completed the program. Our DKA events per patient were not as exciting. There was like a spike in the events from visit 1 to visit 2. There was one patient who actually had like 2 ER visits between those two time points. So that might be a little bit of an outlier, but doesn't look like we've made any major improvements in DKA and ER visits in the cohort quite yet. CGM use, we have had a mild increase in active CGM use. We had 2 patients that at both visit 3 and 4 had stopped using CGM between visits, and then we reinitiated it at that time. So still having issues with sustained use, even though we continue to restart it every time they come into clinic, which is similar to what we see in our regular care. And then with AID use, we did see an increase in active AID use. And more exciting is that we actually have 2 patients that started AID after the final visit. So we did have patients that were engaging in AID education at the clinic visits, and then we're starting AID. So that was exciting. That percentage goes up to like 75% with the 2 that started it after completing the Blossom Clinic program. In terms of engagement, on average, they met with 3 team members per visit. So at the initial visit, they pretty much meet with everybody for the first time, and then it's kind of as needed from there on out. And excitingly, we did have 100% retention. So all of these patients did go to all 4 visits. So that was very exciting. And as I said, of those that did not have AID at the beginning of the program, 63% did receive education throughout the program. All right, so in conclusion, it seems that a multidisciplinary equity-focused design is feasible and acceptable among our patients with complex needs. And there was a very strong engagement with the multidisciplinary team. And it does seem like there have been some improvements in the things that we set out to achieve, which is exciting. But there's a lot that we still need to do. So we are looking to expand enrollment and grow the program. We're looking to, it's QI, right? So we're refining workflows all the time. We're meeting with all the members of our team to ask what's going well, what's not going well, and revising our workflows and our huddle and our between visit check-ins. We're not yet achieving those goals we set for technology sustained use. So we have been actively discussing how we can more finely tailor our strategies to a population with higher and more complex needs and higher barriers to make it more successful. And we continue to collect, longitudinal data on outcomes and look to see how we can kind of scale this and spread it to other locations, because right now we're only doing it out of the main hospital, so making it more accessible. And of course, I just have to say thank you to the amazing team, because everybody added this to their work plate, to all the work they're already doing for our patients. And everybody was so enthusiastic to get on board and help our patients. So I just need to say thank you. A lot of them are in the room now. And that's it.
Great presentation, wonderful work. Any questions?
Thank you for your presentation. Just curious, of the 12 patients, did you have any dropouts from the program? The first presenter said 4 patients dropped out. So I'm just curious if you had any patient.
Yeah, so from the 12, these are the 12 that finished the program. So yes, we've had a couple of patients who have not come to scheduled appointments, and we tried to reschedule them a total of 3 times before we dismiss them from the program, because right now we have such a limited capability and want to make sure we're providing opportunities to people who want to be in the program. So I don't know the exact number. We have somewhere around like 40 patients that are actively in the program, and I think we've had like 3 or 4 that have not have fallen out of the program.
Hi, Christy Corley from Grady Health System. I love that you have such a robust multidisciplinary team. I was wondering what the role of your pharmacist was.
Great question. Yeah, we're so lucky to have a pharmacist. So that was kind of like a superpower that I think is not common to have. So through like PDSA cycles, we actually like refined her role. So in our pre-clinic huddle, she will actually have reviewed, do they have active insurance? Are they consistently filling their refills, both their tech supplies specifically, because sometimes they're getting them differently from pharmacy or DME. She can tell us when the last time they picked up their refills. And then she can like meet with the families to discuss if they're having any barriers to picking up their supplies. The other thing that we're really fortunate to have that just started since starting Blossom is we have like a specialty pharmacy in our hospital that can do scheduled deliveries of supplies, but it's contingent on families picking up the phone to confirm that they will receive the supplies. So we're very often switching families to that option in agreement that they'll be able to, pick up the phone. So we've been really, really lucky to address a lot of barriers around supplies and gaps in supplies with our pharmacist.
Hi, Carla Demeter-Bergum from Rady Children's Hospital, San Diego. First of all, congratulations. This is really music to my ears. Patient and family center care is what we should look for. I wonder if you could comment in terms of, balance measures, if we're talking about quality improvement here, such as bandwidth of your team and cost. Is this embedded already in the insurance, or do you have any other source of funding? And how did you do for bandwidth of everybody's time?
Yeah, great question. So right now we don't have funding. We're looking to get a grant. We're kind of using this as like a pilot to try and collect data and say like, hey, this is feasible. We're achieving outcomes, and we would like more resources. So right now, these are all resources that we have available in our clinic. We have been using some of our social work funds for some of those supplies and transportation finances to help fund those out of, routine care things. Yeah, was there more to the question? I don't remember. That is something that we should look with. I'm curious because suggestions, recommendations that how to make them identify. Sure. So the question, which was a good question, was saying that there's a specialty pharmacy that's able to supply GLP-1s and other diabetes supplies, but not insulin, and how to convince specialty pharmacies to supply insulin. That doesn't make any sense to me. I don't know why they would decide to, fund everything but the most, pressing diabetes supply. So I am not sure how that decision is made, but I think like with everything in QI or research, right? It's like, do you have the data and can you like look at your patients and like the supplies and what they're able to pick up and what they're not able to pick up, and maybe making a case for like, hey, this is a real need and they're needing insulin consistently for their entire lives, and this is something that we should be, offering them because they would definitely be utilizing it.
Other question? Yeah, but I'm going to ask you one more question. Sorry. Yeah. I was just curious, like in your cohort, the people were started on a CGM, but then you had to restart because they didn't use it or probably didn't want to, or whatever the reasons. Did you try to analyze what were the reasons?
Yeah, so we haven't been collecting like concrete data on that, but it's like a very common thing we see in our clinics all the time. So we always kind of ask about it, right? Like we prep the charts, we see they haven't been wearing it. It's like, what happened? We put it on at the last visit. What are the barriers? A lot of times what comes up in conversation is it fell off, I forgot it was there, it's painful, I don't want it to show. And like we feel that we're addressing the barrier at the visit and then we restart it, but then they come back 3 months later and they're not wearing it. So I think similar to some other talks we were having today, it's not necessarily always coming out in conversation what the true barriers are, and we need to do a better job of trying to figure that out so we can actually make progress, because doing the same thing over and over again is very frustrating for everybody.
And the reason I asked is that I think my experience with very few people is that certain people, particularly African American population, somehow that it's not sticky enough to really stay on their skin. And the Eversense has been like really great for those people. And in my opinion, I think the pediatricians generally don't consider that.
Yeah.
The adult side we do, and we don't do a lot of good things, but sometimes we do. And I think one of that part. And so just, that's where I'm throwing up that idea that I think it's not thought about when people are saying that it's not staying on my skin. Yeah, thank you so much.